Hello students, how are you today? So that's me, Dr. Sonal Parihar, and today I'll be doing the recall session on the INICET exam which just happened. So I'm sure you all know the answers by now. You must have checked with your consultants, with your friends, with your books. But today we are just going to discuss what all problems you can have in the options. I found the paper very, you can say very straightforward. The questions were not the INICET level that we normally expect. And the options were also very non-controversial. I mean, I didn't find any question in which the options were confusing. So I hope you found the same. You also felt the same. So it was a very straightforward paper, just 15, 16 questions out of OBGY. That too, I would say there were 2, 3 overlaps between pediatrics, between physiology and microbiology. So if you actually look at that there were just 15, 1-5 questions of pure OBGY. Okay, so let's start. In case you have any query, you can always write in the chat box. Okay, so that's me, Dr. Sonal Parihar. Let's quickly start with the recall session. That's your first question. A woman presents with bleeding since 2 days and abdominal pain. So bleeding for 2 days and abdominal pain. So these are the things which you have to highlight and keep in your mind. But her LMP was just 6 weeks back. So she's just about 6 weeks pregnant, 1.5 months pregnant, right? And ultrasound shows fluid in the pouch of Douglas. And what is the diagnosis? Now this is the main thing which is going to differentiate between two options. So what are the two options which will just automatically get cut? What are these two options? That is abruptio placenta and placenta previa. Why will they get cut? Because this is a cause of APH, that is antepartum hemorrhage. Antepartum hemorrhage, the most important two causes are placenta previa and abruptio placenta, and we know that this is only happening, this happens only once the baby is viable. That means after 28 weeks in India and after 24 weeks in UK, where the viability period is 24. This patient is only 6 weeks pregnant. So the two options left are what? Missed abortion and ruptured ectopic pregnancy. Now in my sessions in Manipal, in my main lectures, in my crash course also, I have so many times discussed all these. What are the symptoms? What are the symptoms of ruptured ectopic pregnancy? Of course the answer is ruptured ectopic pregnancy. Why not missed abortion? Because she will not have fluid in the pouch of Douglas in cases of missed abortion. In missed abortion, she will have pain. She may be pregnant about 6 weeks. She will have little bleeding also. And sometimes missed abortion will come with very little bleeding, just maybe spotting. And once we do an ultrasound, we come to know that the baby is dead. Okay. But the fact that the ultrasound is showing fluid in the pouch of Douglas is diagnostic of ruptured ectopic. So let's quickly enumerate the symptoms of ruptured ectopic. Incidence is 20 to 30 years of age. The classic triad of ectopic pregnancy is seen in 50% of the patients. That is pain seen in 100% patients. Around 75% will have amenorrhea, that is 6 to 7 weeks. It doesn't last for more than 6 to 7 weeks because maximum is up to 8 weeks in the tube. But if it is in the interstitium, remember I told you I think in the prepathon we have discussed this, and if you have downloaded or if you have subscribed for the Manipal crash course, then in that I have told you that if the patient is in the pregnancy is in the interstitium, this is the interstitial part of the tube where the tube is very you can say very thin, but the expansion of the tube can happen within the myometrium of the uterus. If it is there, then it may rupture after 12 to 16 weeks, but otherwise ectopic pregnancy will rupture by 6 to 8 weeks. So amenorrhea in 75%, pain in 100%, and PV bleeding in 70%. Now 10% will have syncopal attack because of peritoneal irritation, and this peritoneal irritation happens because of the blood collected in the pouch of Douglas, which goes and irritates the diaphragm. The phrenic nerve gets irritated, and that gives her the shoulder pain. Now, site of pain will be unilateral because it is one-sided, obviously either right or left, in the pelvic area or the lower abdomen. The histopathology will show an ectopic mass with no chorionic villi, right? Now, chorionic villi will not be seen in the uterus because the uterus will only have area stellar reaction, but chorionic villi will be seen in the products that we remove from the ectopic pregnancy. In endometriosis, it will be secondary amenorrhea, dyspareunia, and infertility. The ectopic pregnancy triad is pain, bleeding, and amenorrhea, which is all there in this patient. Now, in ruptured ectopic, the pain is due to hemoperitoneum or initially due to stretching. Once the stretching is gone, the patient has ruptured herself, the pain definitely subsides, but the pain then happens because of the peritoneal irritation. So more pain is there once the tube, before the tube is actually ruptured. Once the tube is ruptured, then the pain will decrease. Danforth sign is in the ruptured pregnancy, pain is due to stretching of fallopian tube, dermatome T10, 11, 12. That is a supply of the fallopian tube. Culdocentesis is what they have just told you. Culdocentesis means you are aspirating some fluid from the pouch of Douglas. So culdo means, culd is basically the pouch of Douglas, and centesis means you are aspirating the blood. So culdocentesis is a simple technique used commonly in the past when I was doing my residency from 97, 98, 99, these 3 years. How we used to diagnose ectopic was put a big Venflon needle, just take out the stillet and put it inside the pouch of Douglas through the, it was put blindly, just holding the posterior lip of the cervix and going into the pouch of Douglas and then aspirating. Once we get fluid, that means it is a diagnostic of ruptured ectopic pregnancy. Now we don't need to do it because sonography is very, very easily available. Most of the gynecologists are doing sonography. It's very easy. Now, not used for diagnosis, that is when we get blood from the pouch of Douglas, it is not diagnostic. Why I'm telling you this? Because you may get a question in the upcoming exam in the NEET PG. So although we know the answer is ruptured ectopic, but I have taken some slides from my lectures from the Manipal MedAce so as to basically just complete that topic. Okay. So now, culdocentesis, if you are getting blood, it is still not diagnostic because fluid can be aspirated. Blood indicates ruptured ectopic but not diagnostic. Positive test is highly specific. Unfortunately, negative test does not rule out ectopic pregnancy. So if you don't get blood, doesn't mean that it is not a ruptured ectopic. Now, second question, which drug is contraindicated in a patient with atonic PPH with a history of hypertension? Now, history of hypertension, we know uterotonics are given for the active management, and for the PPH, we know so many uterotonics. What are the uterotonics? The uterotonics are oxytocin, carbitocin, ergometrine, 15-methyl PGF2 alpha, that is carboprost, then PGE1 misoprostol, PGE2 is dinoprostone, and tranexamic acid. What have they asked you? Misoprostol, which is PGE1, then ergometrine, oxytocin, and PGF2 alpha, which is prostodin, or you can say carboprost. Prostodin is the brand name, a very famous trade name of the carboprost. So what is the answer? The answer is definitely ergometrine. This is the answer. Now, some students were getting confused. They asked me, why not PGF2 alpha? Why not carboprost? Because it is also given in caution in patients who have high blood pressure in PIH. But no, it is not carboprost. The answer is ergometrine because it is very, very responsible, highly responsible for rise in blood pressure. Thank you, Rahul. Thank you, Rahul. So you have gone through the notes. That's very nice. Okay. Active management of the third stage of labor. Let us just quickly recapitulate what we have read because your NEET PG is coming now. So what is the mnemonic for this? When you actually see the contraindications, this actually, the slide is just upside down. Sorry, I should start with this one first. Tranexamic acid. First of all, let's discuss all these uterotonics one by one. Tranexamic acid is given within 3 hours of PPH. 1 gram is given in 100 ml NS, infused over 10 to 20 minutes. Avoid faster infusion because tranexamic acid can lead to hypotension, not hypertension. Okay, so tranexamic acid is generally given to reduce bleeding even when the patient is menstruating, any kind of bleeding after surgery. So because it is an antifibrinolytic drug, but in PPH it has to be given within 3 hours of PPH. This is the dose, and in faster infusion it may lead to hypotension. Second dose is given if the bleeding reappears in 24 hours or persists beyond 30 minutes. Even after half an hour if she is bleeding, you repeat the dose. Oxytocin is giving the patient physiological contractions. It is a drug used for active management. It is a drug used even during labor, to induce labor, to augment labor. So active management with oxytocin can be done in all cases except the cardiac patients and the pre-eclampsia patients. It does not give rise to high blood pressure, but the pre-eclampsia patients, we do not want a lot of fluid overload because oxytocin acts like ADH, antidiuretic hormone. So the third compartment of fluid might increase, and we don't want the fluid overload to happen in the cardiac patients or the PET patients. So these are the two patients in which we have to be very cautious. Oxytocin is contraindicated in contracted pelvis, malpresentations, obstructed labor, all the conditions where normal labor is contraindicated. So when you're giving oxytocin to augment, obviously when you're giving oxytocin to augment or induce labor, you are wanting a normal delivery. But if the patient is having malpresentation, contracted pelvis, the patient going under obstruction, why will you give oxytocin? So these are the three main contraindications. Apart from that, the hypovolemic state, because it is also leading to, it is acting like ADH. Then the renal disease, it acts on the vasopressin receptors because it is secreted from the posterior pituitary, you know that, and there is another hormone ADH. So kind of same symptoms, same kind of mechanism of action. Renal disease, vasopressin receptors, it will act on, and it can cause fluid retention. So these are the 5 contraindications for oxytocin. Then if oxytocin is not available, WHO has recommended some other oxytocics, which I've just told you. PGF2 alpha is prostadine, carboprost. It is not being recommended by WHO. Okay. Now, argometrine, the answer of this question is argometrine, 0.25 milligram, or we also call it as methyl argometrine, the methyl salt of argometrine, which is in the dose of 0.2 milligram. They bring about tetanic contractions. That is why they are not given during labor. They are not given before the placenta is delivered. Hello, Rahul. Rahul Soni, Rahul Avra. Hello. So, remember that argometrine is basically inducing tetanic contractions. So we cannot use it for induction, we cannot use it for augmentation. Even after delivery of the baby, we do not give it unless the placenta is delivered, because it can lead to tetanic contractions and it can cause the os to completely close, and then it will end up in retained placenta. Okay, hence should not be given for induction or augmentation. It should not be used during pregnancy. For active management, it is given intramuscularly, repeated at 2 to 4 hours interval if needed. So tranexamic acid repeated if the bleeding is persisting up to half an hour. This is repeated at 2 to 4 hours interval. IM dose is given. Side effects are transient increase in blood pressure. So when they ask you blood pressure, the answer is always argometrine, not carboprost. Argot alkaloids, especially when given IV, may cause dangerous hypertension, especially in women with preeclampsia. Hello, Dr. Satyendra. Good evening. So argometrine, also known as methogen, very commonly seen in the private practice, or sorry, not the private, but the practice when we are practicing, whether private or government. So the drug which is very commonly used is methogen. Okay, that is a trade name. Just like I told you, carboprost is known as prostadine, because that is the most commonly used drug in all the government hospitals and even in the private practice. So argot alkaloids, generally they are given IV. I always give it IV. I've been practicing for 25 years. Even my anesthetists, they use it IV, but it can lead to dangerous hypertension, especially in women with preeclampsia. So we do not use argometrine in RH negative pregnancies and in post-delivery, obviously, and in the patients with severe PET. Also, severe hypertension is seen with concomitant use of protease inhibitors used for HIV. If the patient is HIV positive, she is delivering. In that case, if the patient is on protease inhibitors, argometrine can have a kind of you can say reaction with that protease inhibitor and can lead to malignant hypertension. So it can interact with the drug. So what are the contraindications? The contraindications for argometrine are TOPHER, topper, whatever you call it. Now, all the conditions in which it is absolutely contraindicated: twin pregnancy, organic heart disease, preeclampsia. Why twin pregnancy? Because the baby 1 has delivered, but the baby 2 is still there. So you have to be very careful. Don't give methogen before the baby 2 and the placenta is out. The placenta 2 is out. Organic heart disease because of hypertension, preeclampsia, HIV patient on protease inhibitors, eclampsia, obviously because of blood pressure, and RH negative females, because we do not want feto-maternal hemorrhage to happen. So these are the contraindications, and the answer is argometrine for this question. Now coming to just quickly recapitulating the other uterotonics, side effects of PGE1, which is misoprostol. This is misoprostol. Okay, 800 microgram sublingually is the dose. So you give it sublingual 800 microgram, not milligram. Nausea, vomiting, abdominal pain, all the GI symptoms can happen. Shivering, hyperpyrexia, and hypotension. Again, remember hypotension. So hypotension can happen with oxytocin, with tranexamic acid, and with PGE1 misoprostol also. No effect on the asthmatic patients. It doesn't act on the lungs. It is contraindicated in previous cesarean patients because it can lead to rupture of the uterus. Now, PGE2 dinoprostone is very safe. It's dinoprostone. It is the safest prostaglandin because we use it for induction. If you have read Induction of Labor, you will know that dinoprostone is given as either tablet form or gel form to induce labor. It is not recommended as it can cause low blood pressure. Again, hypotension. Okay. So hypotension is again a side effect for this, and 20 milligram, it is not microgram, 20 milligram PV or PR suppository is given for the dinoprostone. Then coming to carboprost, some students were getting confused in this question. Why not carboprost? Why argometrine? The answer is argometrine whenever they talk about blood pressure. Okay. It is also known as dinoprost, hembate, and the dose is 250 microgram, not milligram. It is microgram IM, and the maximum doses, you know, can be given 8 doses. Success rate is 88%. it can cause tetanic contractions, just like the argometrine, just like the PGE1. Avoid in PET, PIH. So all the uterotonics are being avoided in PET and PIH, including oxytocin, because of the fear of overload and hypovolemia. But it is only argometrine which is contraindicated. It acts mainly on the myometrium, hence it is used in active management and in PPH, but not in inducing labor, just like argometrine. WHO does not recommend this drug to be used in preventing PPH. So WHO is recommending carbitocin, oxytocin, argometrine. It is recommended PGE1, PGE2, but not recommending PGF2 alpha. Then side effects are diarrhea, vomiting, fever, tachycardia, bronchospasm, just like the other prostaglandins, because they are causing all the GI symptoms. But the main contraindication or the side effect here is bronchospasm. So we are basically avoiding PGF2 alpha in asthmatic patients. So the contraindication will be bronchial asthma, and it is a high risk for amniotic fluid embolism. For the patients who are at high risk for amniotic fluid embolism, we will not use PGF2 alpha. Then coming to the third question, the most potent natural estrogen. Now, there was a query here. Many students were discussing among themselves. Some of them, they forgot that natural was written. Hi, Dr. Abhinami. Good evening. So, some students were saying natural word was not there. So, they had clicked on EE, but I can't see the option EEA, that is ethinyl estradiol. Ethinyl estradiol is obviously a salt of the naturally occurring estradiol. So if EE is mentioned and the word natural is not there, then in that case you will write EE. But here all the four naturally occurring are basically mentioned: estrone, estradiol, estriol, and conjugated equine estrogen. So what is the most potent one? It is estradiol. Estradiol is the answer. Okay, let's quickly recapitulate what I have taught you in the main app, the Manipal MedAce, and even in the crash course I have told you. Forms of natural estrogen. E1 is estrone, E2 is estradiol, E3 is estriol, and E4 is estetriol. We don't use it at all. So even for me, it is it's very difficult to pronounce. So E1, E2, E3. The potency, E2 is 10 times more potent than E1 and E3. So if you look at the decreasing order, it is ethinyl estradiol, which is not mentioned in the options, and it is basically a synthetic estrogen, not natural. Then comes estradiol, then estrone, then estriol, and then comes estetriol. So they've also mentioned conjugated equine estrogen. Okay, so that is again a basically a menopausal estrogen, which is coming from in the menopause patients. What is happening? The FSH and LH are increasing. So conjugated equine estrogen is given to basically correct the menopause symptoms. E1 is higher in the hyperestrogen condition. Why in the menopause we are giving E3, estriol, that is the conjugated salt of this particular E3, because it is least potent and it will not act on the uterus, and it will not be as dangerous as compared to the E2, because E2 is most potent. So we avoid giving it to the postmenopausal women who just need a very little dose of estrogen to get rid of the hot flushes and the genitourinary syndromes. Now E1 is higher in the hyperestrogenic conditions, because why? E1 is directly coming from androgens. So in the fat, the androgens are getting converted into estrone, and this estrone travels to the ovary and gets converted into E2, right? So estrone is higher whenever the patient is fat, whenever the patient has fibroid. So any condition in which there is a lot of androgens or lot of estrogen conditions, in that case there will be peripheral conversion of androgen to E1. So letrozole stops the peripheral conversion, can be used as a treatment. So E1 is higher in fibroids and PCOS patients. In that case, if we give letrozole, it is an aromatase inhibitor. It will not let E1 to androgens to get converted into E1. So it is an aromatase inhibitor. Estrogens are bound to albumin 30% and 69% to SHBG, and we know that estrogen increases the SHBG production, and remaining free 1% is biologically active. Okay, this is all you need to know about estrogens. I just wanted to complete that topic, so I took some extra lines from my lectures. Now, a patient presents at 36 weeks with chronic hypertension. Okay, very important. First of all, 36 weeks is very important. 36 weeks tells you what? It tells you that the patient has crossed the 34 weeks, after which we do not give steroids. I have told you in the chapter in preterm, you must have read it. Go through the chapter again if you don't remember it. We don't give steroids after 34 weeks. Okay. Some theories are there that you may give it up to 37 weeks, but ACOG recommends not to give it after 34 weeks, otherwise it will lead to other complications. So 36 weeks, the answers which are saying steroid, corticosteroids will be gone. So these two you can simply cut, because it is saying corticosteroid. 36 weeks, she's almost done. Chronic hypertension, so obviously she will need what? She will need antihypertensive. Okay, so the next two options are both having labetalol, because the hypertension is 170 over 100. That is very, very high. Then she is having 3 plus proteinuria. We know proteinuria is not used in the definition of severe preeclampsia now, but proteinuria indicates end organ damage, means the kidney is getting damaged, and 3 plus proteinuria is really indicative of end organ damage. Then she complains of headache and blurring of vision. Blurring of vision again along with 3 plus proteinuria means she is going towards eclampsia. She is in impending eclampsia. So what are the indications in which we just simply terminate the pregnancy without considering what is the gestational age of the patient? So indications for termination irrespective of the weeks in case of preeclampsia are, first of all, impending eclampsia, which our patient is already there. Eclampsia, she's already, means if she's already convulsing, then you give magnesium sulfate and followed by induction of labor. So do we have that option? We have this option, labetalol with magnesium sulfate in both. The other option which is confusing is whether you deliver right now or you wait till 37 weeks, means you wait for another 1 week. So the best answer what they have asked is this one, expedite delivery. What will you gain by just simply waiting for another week when she's already in end organ damage, in impending eclampsia? You might have to just, they're already giving magnesium sulfate because they are suspecting eclampsia. So you think about the options, why the examiner is giving magnesium sulfate in both the options. For example, in this particular case, if they had not given magnesium sulfate, or in this particular option they had not given magnesium sulfate, then you would have thought, okay, she's probably not impending eclampsia, she's just a severe PET, so maybe we can give labetalol and we can then wait for till 37 weeks and conduct Dopplers. So that is again a good answer, but that option is not there. Okay, so if they are giving you magnesium sulfate in both the options, means they are assuming that she's going towards eclampsia. So when you're giving magnesium sulfate, remember children, I have told you in the lectures that magnesium sulfate is a respiratory depressant for the baby also. So when we are giving magnesium sulfate, we are planning delivery within 24 hours. Within 24 to 48 hours, we have to plan delivery. So this is the best option here. Okay, so the other indications where we terminate the delivery without waiting for the gestation is HELP syndrome. So eclampsia has happened, HELP syndrome has happened, so don't wait for 48 hours. Abruptio has happened, obviously you have to simply deliver the baby, otherwise the baby will die. Pre-viable fetus, what is the point of putting patient under risk if the baby is not going to survive anyway? Okay, then you just have to simply throw out the defective placenta. Fetal compromise, the NST is telling you that the baby is about to die, baby is not well, then why will you wait? Fetal death, baby is already dead. Uncontrollable blood pressure, rising serum creatinine, again end organ damage, progressive organ damage, reversal of EDF in umbilical artery Doppler. Umbilical artery Doppler is very important. They asked another question on this. End diastolic flow is reversing, so it is REDF. REDF means impending IUFD, the baby is about to die. So these are the indications where you do not wait for the gestational age to become better. Okay, an 18-year-old with primary amenorrhea presents to the OPD. An 18-year-old with primary amenorrhea presents to the OPD. She has Tanner stage 4 secondary sexual characteristics. Her karyotype is 46XX. FSH is 5 and LH is 13. Now this particular line is just to confuse you, because when you see that the ratio of FSH and LH is 2:1, then what rings in the bell, what kind of options come to your mind? That is PCOS. And this is exactly what I thought. I did not see the options, but once I looked at the main question, I thought, okay, 18-year-old, the most common reason for amenorrhea can be PCOS. Although not primary, it is generally secondary, but it may happen in primary also. But the good thing is they have not given you that option. PCOS is not there in the option. So the options are gonadal dysgenesis, Mullerian agenesis, Coleman syndrome, and androgen insensitivity. So before I jump into my slides, what I have taught you before, and just quickly recapitulate these particular syndromes, let me tell you, it's very easy question. She is a 18-year-old girl. Obviously now she will be diagnosed as primary amenorrhea because she has crossed that 15 years of age. She presents to the OPD with good secondary sexual characteristics. Good secondary sexual characteristics means a good Tanner stage 4 breast, then karyotype is 46XX. So they've told you that she is not a hermaphrodite, she is not a male hermaphrodite, she is a female, a genetic female. Okay, now gonadal dysgenesis. In gonadal dysgenesis, it can be ovarian gonadal dysgenesis or testicular gonadal dysgenesis. If it is testicular, then it goes into Swyer syndrome. Okay, if it is XX gonadal dysgenesis, that is X0 syndrome, or you can say a variant of Turner syndrome. Okay, in that case, in any case, why will the breast develop? The breast will not develop. There will be no hormone. Then Mullerian agenesis. Mullerian agenesis is the answer here, because in Mullerian agenesis, it is just the problem in the Mullerian ducts which are forming the uterus. So there is a problem in the uterine development because of the improper fusion of the Mullerian ducts. They degenerate, but there is no problem in the ovaries. The ovaries are absolutely intact. They are producing estrogen, so the patient has good breasts. She even has pubic hair. So in that case, she is basically technically a female. She's genetically a female, phenotypically a female. The only thing lacking is a full vagina. She has a blind vagina. Okay, she has a blind vagina. Some of you had mentioned that probably in this question there was a blind vagina also written, but I have not included that because I was not sure what kind of question came. But this itself is enough from the options, because gonadal dysgenesis will not give a good quality of breast. Coleman syndrome is GnRH deficiency, where the neurons coming from the hypothalamus which are carrying GnRH are absent. In that case, it will be totally stunted patient. The pituitary will not be stimulated, the FSH-LH will not be there, the ovary will not be stimulated, so she will be totally hypogonadic, hypogonadotrophic, hypogonadism type of picture. Androgen insensitivity will have good breast. Yes, they will have good secondary sexual characteristics, and that too breasts. Tanner stage 4, 5, but they will not have pubic hair, which is not mentioned here. But the thing is, they will be XY. They are male hermaphrodites. They are not females. It is androgen insensitivity. So the fact that she's 46XX and she has secondary sexual good breast developing, and she's come with primary amenorrhea, the only thing which goes in favor is Mullerian agenesis. Had they mentioned PCOS, I would have been confused whether it's PCOS, because they've mentioned FSH5 and LH30. Okay, so that is something confusing here, but because they've not given the option of PCOS, so that is to be omitted. So this is a screenshot from the slides that I have basically taught. This is a crash course that I've done in Manipal MedAce. You can just subscribe to the crash course if you do not want to take the entire app. So in Turner's syndrome, there will be streak ovaries. It is a X0 gonadal dysgenesis. Pure gonadal dysgenesis is when there is XX and XY both, and Swayer's syndrome is simply XY. Okay, what is the difference between androgen insensitivity and Swayer's syndrome? I'll tell you. Now, streak ovaries are seen in Turner's because they will be, one X is absent, so the estrogen level will be low. The Mullerian ducts will develop, but the uterus will be very infantile because there will be less estrogen for them to grow. The uterus will not grow properly. So, pure gonadal dysgenesis, it will be 46XX. These will be short statured because of some other gene which I am not going to discuss here, but only the Turner syndrome patients are short statured. Otherwise, the pure gonadal dysgenesis and Swayer's syndrome are absolutely normal height. Web neck, CVS problems, hypoplastic uterus, streak ovaries, all are seen in Turner syndrome. Web neck and CNS problems are not seen in pure gonadal dysgenesis or Swayer's syndrome. But when it comes to hypoplastic uterus, it is there in pure gonadal dysgenesis because the gonads are not working properly. Okay, in Swayer's syndrome, it is XY. So they will have testes, but they are streaked testes. So if streaked testes are there, testosterone will not be there. Wolffian duct will not develop, obviously. Wolffian duct needs testosterone to develop, so it will not develop. What will develop? Because they have testes and AMH is not getting secreted. Because streaked testes means it is not secreting testosterone, it is not secreting AMH. So if both are absent, even AMH is absent, Mullerian duct will develop. So they will have a hypoplastic uterus. Why hypoplastic? Just like Turner's, they do not have enough estrogen for the uterus to grow. It will grow, it will fuse, the Mullerian duct will fuse, but it will not grow because ovaries are not there. Okay, and there will be testes. External genitalia will be infantile female, again because of lack of estrogen. This will be a normal female. Okay, and this one will have ambiguous genitalia. Generally, they do not actually have the penile growth. Obviously, they are XY, but their gonads are dysgenetic. And because the Mullerian duct has developed, they will be maybe a small vagina, kind of ambiguous genitalia, which resembles female. Now, coming to androgen insensitivity, which is also a part of male pseudo-hermaphroditism. So, just quickly recapitulating so that you can understand and you can revise what you have read so far. It is a X-linked recessive disorder, complete X-linked recessive disorder. I am not talking about the incomplete, the Riefenstein syndrome and all. XY is the genotype. Testes are seen in the inguinal region and they need to be removed. Inguinal hernia is there because they are undescended testes. Sertoli cells, they form AMH, hence the Mullerian duct regresses. In androgen insensitivity, it is not a dysgenetic gonad. It is a normal testes which is secreting AMH also, and it is secreting testosterone also. So testosterone is getting secreted. So obviously what is happening? The internal genitalia should develop. That is means the Wolffian duct should develop. But because there is androgen insensitivity, the testosterone is not able to act. The receptors are not accepting it. So in that case, the Wolffian duct will also not develop. So Wolffian duct will degenerate. because of lack of testosterone acting receptors. There is no estrogen because AMH is there, so Mullerian duct is also regressing. So what is happening? Internal genitalia in androgen insensitivity is absent. Okay. Leydig cells, they secrete testosterone and there is insensitivity to testosterone. That is why the Wolfram duct degenerates. External genitalia will be like female because it is default. The external genitalia, when they don't get enough testosterone, it develops into a female. That's a default external genitalia. They will have good breasts, but they will not have pubic hair because androgens are insensitive. Testosterone gets converted to DHT, but it is insensitive. No pubic hair, so pubarche, adrenarche will not be there. Undescended testes with high chances of malignancy, they have to be removed. Fully developed Tanner stage 4 and 5 breasts, because whatever androgen is there, it is getting converted into estrone. Estrone is forming, so estrogen level will be high because this androgen is not acting anywhere, it is just getting converted in the fat to E1. Now, female external genitalia will be there because by default it will look like a female and with a short blind vagina because there is no uterus. So that vagina, the 2/3 upper vagina, the upper 2/3 of the vagina develops from the Mullerian duct. The lower 1/3 comes from the sinovaginal bulbs. So that is developing. So that's a short blind vagina and no or scanty pubic hair. Swyer syndrome is pure gonadal dysgenesis, 46XY again. The difference between androgen insensitivity is that this testis is not acting. So neither AMH is developing. So neither AMH is secreted and even testosterone is not there. So no testosterone means the Wolfram duct will not develop. In androgen insensitivity also it did not develop because testosterone was there but it was not getting active on the receptors, but they were not accepting. Hello Gagan Kachawa, good evening. AMH is not there, so Mullerian duct will develop. It will develop definitely. So absent testosterone, gonads are testes and they are dysgenetic. Okay. 85% unknown cases, 15% due to mutation in the SRY gene which is located on the Y chromosome. Undescended testes, there will be increased chance of malignancy just like androgen insensitivity. Now, the mutations can happen in all these genes. Read this, very important, it's very important children. SRY gene, SOX9 gene, NRSA2 gene, DEXA gene and SA1 gene. All these you have to mug up. Okay, these are the genes responsible for spermatogenesis and development of the Wolfram duct. Internal genitalia will be like female because AMH is not there, so Mullerian duct is going to develop. Uterus, cervix, upper vagina will develop. Wolfram duct will degenerate because there is no testosterone. So internal genitalia is female, although in androgen insensitivity, internal genitalia was absent. External genitalia may look like females, obviously by default. So just like androgen insensitivity, but they will not have a very good breast development. The Tanner stage 4-5 will not be there because there is not enough androgen to get converted to estrogen. That is the difference between androgen insensitivity and Swyer syndrome. I hope I'm clear. Once you actually start thinking how it works, then it becomes easy. You don't have to mug up. I have also not mugged up. I have just kind of used my knowledge theory that if testis is working, it will secrete these hormones. Receptors not working, which hormone will not work, what will happen to the rest of the hormones. So this is how you learn and understand. Adrenarche does not happen because testosterone is not there. It is not that it is not acting on the receptor, it is not there at all. There will be no breast development because there is no estrogen getting converted, androgen getting converted. Then delayed puberty, normal height, short height is only seen in Turner syndrome, and tall is Coleman syndrome. Okay, sorry, tall is XYY, that is XYY, Klinefelter syndrome. They are tall, it is not Coleman's. Then primary amenorrhea and high FSH and high LH because it is a dysgenetic gonad, so it's the hypergonadotrophic hypogonadism. Now, class 1 Mullerian agenesis, aplasia, hypoplasia, coming to Mayer-Rokitansky-Kuster-Hauser syndrome. So you know that there are 6 classes, class 1, class 2, class 3, biconjoid, septate and uniconjoid. All these come one by one. So let's just discuss Mullerian-Rokitansky-Kuster-Hauser MRKH syndrome, also known as Mullerian agenesis. Both the Mullerian ducts are absent, MRKH syndrome, and it is seen only in 1 out of 50,000 or 20,000 incidents. But I'll tell you what, I have been practicing for 25 years. I have seen many patients so far in 25 years. So I feel the incidence is probably increasing or the awareness is increasing. It is not as low as 1 in 20,000. Okay. Now, familial tendency is there in 7 to 8%. Causes may be polygenic, multifactorial, teratogens, environmental. I would say it is just sporadic because in the same family, there are 3-4 sisters. One of them is defective and the other ones are fine. So it is mainly just simply idiopathic. It just happened because they're eating the same food, they're living in the same environment, mother and father are conceiving children in the same kind of environment. Still, one female is not developing the Mullerian duct, others are developing, then it is basically idiopathic. Karyotype is XX, Secondary sexual characteristics are present. There is no problem in androgens. There is no problem in estrogen. Breast developing, pubic hair, axillary hair, everything developing. Primary amenorrhea because the genitalia is absent. They only have a small lower vagina, the blinding vagina, because it comes from the sinovaginal pubs. But sometimes even that is absent. Even a small dimple is there. And the ovaries are present with normal ovulation. Such patients can conceive with surrogacy. They can donate their eggs. Then coming to the next question, question number 6. Primary gravida is in the second stage of labor for 2 hours. The head is at +3 with caput present and the FHR is dropping to 90 beats per minute. What is the best way to deliver the head? Can somebody answer this for me? I'll take a small 1 minute, 10 second or 15 seconds break. Anuj Sharma, okay. Outlet forceps. Fine. Anybody else? Okay, that is the answer. Outlet forceps. Outlet forceps, why? First of all, mid cavity and low forceps have now been removed. Nobody does that, okay? Because they are, especially the mid cavity forceps, very, very dangerous for the baby and even for the mother. So first of all, you need to see that the head is at +3 with caput. So there is +3 means the ischial spine has already been crossed. It is 3 centimeters below the ischial spine. So it is at the level of the outlet. Now, the patient is in the... Sorry. Yeah. The patient is in the second stage, primary gravida. She is already in prolonged second stage. The baby is at the outlet. So what will you do? And the baby's heart rate is dropping. So you need a quick procedure. So the quick procedure will be outlet forceps rather than ventouse, because ventouse doesn't work well with caput. Caput and ventouse don't go well because then the ventouse will not be able to create a vacuum. So yes, the answer is outlet forceps. Low forceps and mid cavity is not the answer. Very simple question. Okay. Then coming to the next question, which will you not see in twin pregnancy? Now again, can you answer this for me? Very simple. I told you the questions were very, very simple, and I just hope the NEET PG is also as simple as this one. I just hope the opposite doesn't happen. This was a level of NEET PG, and NEET PG should not become like INICET level. Okay, anyone? What will you not see? Very simple. You see monochorionic monoamniotic, yes. MCMA. You see monochorionic diamniotic, yes. You see monoamniotic dichorionic. Never seen this. How can it become a monoamniotic and dichorionic? Once it starts dividing, it has first chorion and then it is amnion. Okay, so it cannot be the opposite way. So it is definitely monoamniotic dichorionic, which is not seen in twins. Diamniotic dichorionic is very commonly seen. Okay, let me explain this. This is a screenshot of what I have taught in the Manipal MedAce app. So I have told how it divides and becomes dichorionic diamniotic. This is a monochorionic and diamniotic, and this is a monoamniotic monochorionic, where it is dividing after 8 days, and after 13 days they become conjoined twins. Okay, so that is the clearer picture. What you can see, this is a DCDA, this is MCDA. So this is dividing in 3 days, this is dividing within 8 days, this is between 8 to 12 days, this becomes monochorionic monoamniotic, and this one here is monochorionic monoamniotic conjoined twin. So this is a conjoined twin, because it is happening after 12 days, after 13 days. So that is very, very simple. Now, next question, question number 8. Dose of corticosteroids for lung maturity. Okay, Dexa 12 mg 24 hours, 2 doses. Dexa 6 mg 12 hourly, 4 doses. Betamethasone 12 12 2 doses, or 12 24 4 doses. Tell me. Remember how you remember it. It's very, very simple. Dexa or beta, both have to be given. The total dose has to be finished in 48 hours. Okay, and the total dose which goes in is 24 mg. So that helps you in getting the right answer. See, if I look at the first option, dexamethasone 12 mg in 24 hours, 2 doses. Okay, so this seems okay, but there is something wrong in it. But if you look at this calculation, then this goes with 48 hours, and in 24 mg she's getting it. So betamethasone 12 mg in 24 hours, 4 doses is wrong, because we don't want 4 doses. Okay. Betamethasone 12 mg 12 hourly in 2 doses is wrong, because we have to see it has to be 48 hours. Okay. So if this was 24 hours and 2 doses, this would have been correct. So both are wrong. So betamethasone is 12 mg in 24 hours unless it's an emergency, and 2 doses. So this is how it goes with beta. This is beta. 12, 24 and 2 doses. Beta. Right? Dexamethasone 12 mg 24 hours, 2 doses. No. It has to be given 6 mg 12 hourly in 4 doses. So in 12 hourly we are giving 6 doses means in 48 hours we are giving 4 doses. So that is 6 into 4, 24 milligram is getting in the patient within 48 hours. So remember, for DEXA it is 6, 12 and 4. For beta it is 12, 24 and 2. 12, 24 and 2. This is how you have to remember. Very simple. The total dose has to be 48, the total dose has to be finished in 48 hours, and the total amount of drug is 24 milligram. Betamethasone is in a higher dose, DEXA is in 4 divided doses. Okay. Hello Surbi, good evening. Okay, so this is a screenshot from the app, the Manipal MedAce app. 2 doses of betamethasone 12 milligram given IM 24 hours apart. So 2 doses 12 milligram 24 hours in 12, 24 and 2 doses. Okay. This is 6 milligram in 12 hours and 4 doses. 6, 12, 4 and 12, 24, 2. If you can remember this, it will be very easy. And this is cheaper. Dexamethasone is cheaper. Then coming to the next question. All are criteria of IUGR except. Tell me. Give me the answer. Abdominal circumference less than 3rd percentile. Estimated fetal weight less than 3rd percentile. Absent or reversal of diastolic flow in umbilical artery or uterine artery PI, that is pulsatility index. What is PI? It is pulsatility index. Means how much pulsatility is there? Pulsatility index. Okay, any answers? Okay, Ashutosh is saying D. That is the correct answer. Can you tell me why this is the answer? What is wrong in this question? In this option. Yes, Anuj, it is D. There is some problem in this question, in this option. Uterine artery is what? When we do a uterine artery Doppler, we predict preeclampsia. Uterine artery is the umbilical artery. Okay, yes, you are right. Umbilical artery should have been there because when we are looking at the fetus, the baby is getting blood from the uterine artery, from the mother, right? So that is the first thing to show a notch at 20 weeks because we know the trophoblastic invasion is happening at around 16 to 18 weeks is the second wave. Okay. So the predictor for preeclampsia will be uterine artery pulsatility index is increasing. It is more than 95% or resistance index is increasing. Okay. So RI is increasing, PI is increasing or PI is decreasing. That is basically in the uterine artery in the predictor of PIH. But when it comes to IUGR, we have to check for the size of the baby, the fetal weight, the abdominal circumference or the umbilical artery EDF or RDF, that is reverse or absent end diastolic flow. Okay, so you're correct. It should be umbilical artery, not uterine artery, and it is a predictor for preeclampsia. Means it is suspecting placental insufficiency, not IUGR. So IUGR restriction is said to be present in those babies whose birth weight is below the 10th centile. They have said 3rd because that's severe IUGR. When it is less than 3rd, it becomes severe. Or abdominal circumference less than 10th percentile. So effective weight is less than the 10th percentile of the average of that gestational age, or the AC is less than the 10th percentile of that gestational age. Now, 30% SGA, when we talk about SGA, that is the small for gestational age babies, 70% are constitutionally small where the AC will be more than the 10th centile. So yes, you must have read in IUGR that how do you diagnose whether it's a small for gestational age, constitutionally small baby, or it is actually a growth retarded baby. When it is not less than 10th centile of an average AC or average effective weight at that age, at that gestational age, that means it is a small baby but it's not growth retarded. 70% of these are SGAs. Now, 30% of these can be symmetric or asymmetric IUGRs. I'm not going to the details of IUGR. Symmetric means it is kind of from the very beginning the IUGR was developing, so they will have a symmetry in the shrinkage of head, shrinkage of abdomen, shrinkage of femur length. Everything will be small. But when it's asymmetric, in that case the AC will be small, means the abdominal circumference, which is a very effective predictor for IUGR, the growth restriction. In that case AC will be small, but FL will correspond to the gestational age. There will be a brain sparing effect. The baby's head will be bigger than the femur length as well as the abdominal circumference. So that's symmetric and asymmetric. Now, IUGR is characterized with abnormal Doppler studies and oligohydramnios. So when it is mild, it is around 10th centile, means the AC and the effective weight. Moderate is between 3rd to 10th, and severe, which is in your question, is less than 3rd centile. This is the graph I told you in the lectures, if you have seen my lectures. So this is in the center is the 50th centile, above that is the 90th centile, then comes the 10th centile. So our IUGR babies will be below this, 10, 5 and 3. Okay, Now, next question. Following delivery of a preterm baby, the baby died in the NICU despite all efforts. What medication would be given to the mother for reducing the breast tenderness? Now, this is an overlap between pediatrics and obstetrics. Now, we know, I have told you in the hormones and gynecology, you must have read that in breast tenderness, what is happening? Okay, I have got the answer here. Anuj, yes, very, very good. You're saying cabergoline. Now, I have not included any slide here because I just want you to understand. It's very easy. You will not, of course, say ergot alkaloids because it is ergometrine. It is used for PPH. It is ergometrine. Misoprostol, again, is a prostaglandin. For breast, you need something to suppress the breast milk because the baby is dead. They have told you the baby is dead. Had it been the baby is alive but is not able to feed properly, in that case, you will not give cabergoline. In case the question was that the baby is a preterm baby and baby is admitted in NICU, not able to take the mother's milk, the feeds are not yet getting in. So what will you do with the lactation? She is having breast tenderness because she is having engorgement. In that case, you will tell her to do hot fomentation of the breast, manually express the breast. She can throw the milk because it is getting secreted and it is getting forming again. But you will not stop the production. Here you have to stop the production. No, it is not 1 milligram per day. It is 0.5 milligram per day. 0.5 milligram per day. Just check with your pediatric books what is written. But normally in practice, we are giving 0.5 milligrams per day for at least 5 days. And we tell the patient to tightly strap the breast. Tightly strap the breast because breast is just a potential reservoir of milk as well as fat. So whatever fat is there, it has a lot of ducts inside it. So if we tell her to express the breast and reduce the milk inside the ducts, they will fill up again with milk because they will get a lot of space again. So when you have to suppress and completely stop the lactation, you have to tell her to tightly strap her breast so that the milk doesn't get any space to fill up. Okay. So it is 0.5 milligram per day. Thank you. You're welcome, Anuj. Tightly strap the breast rather than expressing. So if the baby is alive, you tell them to express, use hot fomentation so that the pain is reduced, give her painkillers. In this case, you will give her painkillers, you will give her analgesics, but you will tell her to tightly strap the breast and you will give her a milk suppressant, that is cabergoline. Dopamine can also be used, but dopamine doesn't come in the form of drug. This is a dopaminergic drug. Dopaminergic drug. Right? So dopaminergic drug is going to act against the prolactin and going to reduce the prolactin. So cabergoline and bromocriptine are the options, but bromocriptine is not used anymore because of the side effects. So the answer is cabergoline. Okay. Next, coming to the 11th question. O negative female with B positive husband. So she is an Rh negative and a positive husband, Rh positive, delivered a baby. Okay. Now we know that a negative patient can definitely doesn't have D antigen, and a positive husband can be heterozygous or homozygous. So let me just tell you how we actually calculate. For example, this husband is D and D. Okay. Or can be simply DD. The mother is DD. She is negative. So if this mother is crossing with this particular partner, then what will happen? 4 out of 1 means 75% babies will be Rh negative and 25% will be Rh positive. In this case, if she is crossing with this particular person, let me use a different color, DD, that means a homozygous person, then 50% will be, in fact all DD, yeah, so all 100% will be Rh positive. Okay, just something that came across my mind, nothing related to this question, just wanted to tell you how we actually sometimes check heterozygosity and homozygosity when we don't know exactly what's happening. And they may ask you INICET level question that what is the possibility of this baby being Rh positive or Rh negative. Okay, now this patient has received anti-D prophylaxis at 28 weeks. Okay. Why we give 28 weeks prophylaxis? We know that because that is the maximum, that is the time, the most dangerous time at which the fetal-maternal hemorrhage can happen. She's just entering the 3rd trimester. Moreover, the half-life of the anti-D is such that it gives protection till the delivery. Now, in which of the following conditions will you give anti-D post-delivery? So, when will you give anti-D? Remember, anti-D is an immunoglobulin which is going to, it is a very, you can say very mild immunoglobulin, not a very immunogenic immunoglobulin. It is an antibody which is going to coat the fetal antigen, the fetal RBCs which are Rh positive in the maternal blood, because you are giving the injection to the mother. So that anti-D is going to coat the fetal antigens which are containing the anti-D, and this anti-D is going to coat it. So the maternal immune system, this is the maternal immune system which is going to produce the antibodies. It is not able to recognize this antigen because this is a coating antibody. So anti-D is basically going to coat. So when will you give this anti-D? You will give this anti-D only if the baby is Rh positive. If the baby is Rh negative, the blood of the baby which is entering the mother is also negative. So there is no antigen for the mother's immune system to get triggered. Okay. So the answer will be when the baby is positive. So obviously these two will be gone. Okay, so baby positive and the DCT, the direct Coombs test, is negative. Right, Anuj, it is D. Why the direct Coombs test has to be negative? If it is positive, means the baby has already developed antibodies, means the patient is already isoimmunized, the antibodies have traveled into the baby and they are already causing hemolysis. So what is the fact, what is the point of giving anti-D? Means the next baby which the mother is going to deliver will already be attacked with the antibody which is there in the mother. So there is no point giving more antibodies. Okay, so this is the answer. Good. Then, a woman with a history of painful genital ulcers 1 year back has a neonate of 1 week who has lesions on the face and body with neurological symptoms. So this neonate means it's about 1 year old, and this mother had this painful genital ulcer when she delivered. So she had this disease. What is your diagnosis? Very simple. I don't need to ask you the answer also. Very straightforward. It is herpes simplex virus. Definitely not toxoplasma. Definitely not CMV. They will be just simply viral infections. Rash-like symptoms. Varicella zoster is not going to present like neurological symptoms because herpes is basically going to attack. It lives in the neurological, the nerves, the dermatomes. It lives there. It lives in the ganglions and gets reactivated again and again, and the pain is along the dermatome. So for example, if the patient has herpes here or in somewhere here, so whatever dermatome that nerve is supplying, the burning sensation of that particular pain will be there according to the dermatome which is that nerve is supplying. So it is a neuralgic pain. So lesions on the face and neuralgia. So this is again a screenshot of what I taught in the Manipal MedAce. You can go through the crash course if possible. Generalized vesicular rash in the various stages will be there. They will be vesicles. There will be no neurological symptoms. Macule, papule, vesicle, and then it will just burst off. Crusting will be there. Neonate can develop pneumonitis, hepatitis, and a meningoencephalitis. There will be no lesions and there will be no neurological symptoms. So this is how the varicella baby will look, the chickenpox baby. But the herpes infection, these will be the kind of vesicles, the pain, the vesicular, multiple painful vesicles will be there. On the vulva, no rashes on the other part, that's the mother, and in the baby it will be like this. Incubation period is 3 to 12 days. Very straightforward questions. Patient presents at 18 weeks with a low risk of trisomy on quadruple marker and high risk of NTD. What is the next best step? I have not taken any screenshot from the app because it is kind of, I've explained anomaly scan in a different chapter, amniocentesis and CVS in a different chapter, NIPT in a different chapter. So basically they are not linked. Now we know NIPT is a non-invasive test, just like you do a quadruple marker, just like you do a triple marker, or just like you do a double marker. So triple and double marker are basically, triple is not done anymore. In double marker, you are checking in the first trimester the 2 parameters, PAP A and the other one. So basically you are checking the biochemical markers. Then in quadruple, you are checking 4. If this is high risk for Down syndrome, trisomy 13, trisomy 18, in that case you go for NIPT. And if this is also not assuring, then you go for amniocentesis and CVS. So what are we doing here? We are basically checking for trisomies. We are checking for chromosomal problems because we are picking up the fetal cells from the amniotic fluid or from the chorionic villus biopsy or from the NIPT. We put the basically needle in the mother's vein, and we assume that some fetal cells, free floating fetal cells, will be there in the maternal blood circulation, and that is how we get to know whether this baby is having this problem. So these are the invasive and the non-invasive tests. But this patient is high risk for NTD, means the alpha fetoprotein, the MSAFP. The maternal serum alpha fetoprotein detected in the quadruple marker, the blood test, has been high as compared to the other parameters which was normal. So MSAFP is high, NTD is there, high risk for that. In that case, what will you do? You will only do an anomaly scan. This is something I would say an INICET level question, because then this basically you have to recapture whatever you have read so far in so many different chapters. It is not one chapter. Okay, so it's anomaly scan which is routinely done in all the patients at 20 weeks, 18 to 20 weeks, because it's a neural tube defect that you are suspecting, that will definitely be detected in anomaly scan. Then coming to the 14th question, young girl presents with retention of urine, cyclical abdominal pain. On examination, there's a tense bluish bulge seen at the introitus. Very, very simple. Retention of urine, cyclical abdominal pain means she is menstruating inside. She's come with primary amenorrhea. Retention of urine means there is a lump there which is kind of pulling the bladder and simply distorting the angle between the bladder and the urethra. So that is definitely imperforate hymen, where she is menstruating but the blood is not able to come out. Now somebody might get confused between transverse vaginal septum. Let me just tell you how they present. Now, this is a longitudinal vaginal septum. That is also an option here, vertical vaginal septum. So, longitudinal vaginal septum is nothing but a continuation of a septate uterus. So, if you have seen a septate uterus can be partial septate or it can be a complete septa. So, partial septate like this, or it can be complete septa till the vagina. So that's a vagina. So that is a part and parcel of this lateral fusion of the Mullerian duct. So there is a septa in between which is dividing the vagina also. Sometimes the septum may fuse with one vaginal cavity. So this is the vertical septum. They will not present like this. Okay, there is a septum but there is still an opening. So she will still menstruate. It is only during sexual intercourse that she will have the pain. The partner will complain that he's not able to have a proper sexual interaction with the patient, and the patient will have pain because of the septum. Imperforate hymen will obviously present like cryptomenorrhea, means there is amenorrhea happening. There is no problem in the outlet. There is no problem in the genital tract. The uterine cavity, the cervix, everything is fine. It is just the outlet is a problem. Most common cause of hematocolpos, because obviously when the blood is not able to come out, it will collect here, it will collect in the vagina. Everywhere hematocolpos means collection in the vagina, and then there is a membrane, that is a imperforate hymen. So hematocolpos, hematometra, and hepatosalpinx also. The salpinge, the fallopian tube will also be full of blood. Hypogastric lump, because this blood will collect in the hypogastric and it will pull the bladder up. So there will be dysuria, there will be retention of urine, there will be elongation of urethra, cyclical pain will be there, and it will be sometimes in newborns. Sometimes you may see a mucocolpos. It is nothing related to your question, but just because I picked up from my notes. So yes, mucocolpos was mentioned there. So mucocolpos means mucus filling in the vaginal cavity. So this is imperforate hymen. Now because imperforate hymen looks so bluish, why does it look so bluish? Because it is a very thin membrane. Hymen is a very thin membrane, so we can see blood from inside, the collected blood. In transverse vaginal septum, it will not look bluish. It will not be so thin that you just simply give an incision and it will stop, it will come out flowing. It is a simple hymen which gets ruptured during sexual intercourse. You can imagine how thin it is. So that is why it is bulging and it is bluish. The transverse vaginal septum will not look like this, okay? And the transverse vaginal septum, most commonly, it is between the upper vagina and the mid vagina, in the higher area. So this is the high one, this is the mid septum, and this is the lower septum. 30 to 40% will be middle, 10% will be lower. If it is perforated, then there will be no menstrual complaint. Just like the longitudinal vaginal septum, she will menstruate, she will have passage to menstruate. It's only in the sexual activity the pain will be there. Similarly, if it is perforated, there will be no problem. The menstrual activity will happen, but there will be no proper sexual activity because there is a membrane covering the blocking the vaginal cavity. If imperforate, then it will present like cryptomenorrhea, just like the imperforate hymen, but the bluish bulge will not be there. There will be cyclical pain, there will be collection everywhere. Yes, hematocolpos, hematometra, everything, suprapubic bulge will be there, retention of urine will be there, but what will not be there? The bluish bulge will not be there. Remember this, okay? Then, coming to the second last question. A woman presents with dysuria and yellowish discharge. So there is dysuria, urine problem. There is yellowish discharge. Gram staining shows gram-negative diplococci. What is the diagnosis? I'm sure you know the diagnosis. I have basically asked the dermatology lady in Manipal, and she's already, I think, taught you these chapters, this sexually transmitted diseases, because it's basically an STD, what they have asked. Okay. So what is the answer here? Tell me, Anuj, are you going to answer? It's again an overlap between dermat, STDs and vaginal infections, and of course gynecology. So is it trichomonas? It's a gram-negative diplococci. Trichomonas is what? Trichomonas is it is not a bacteria, right? It is a spirochete. It's not a spirochete. I'm sorry, I'm mistaken. Trichomonas is a protozoa, I think. Trichomonas. Yes, Trichomonas vaginalis is a protozoa. It is a protozoa. Yes, I forgot. Yeah, Neisseria. Very good, Rahul. So it is Neisseria. Neisseria are nothing but the diplococci, the gram-negative intracellular diplococci. They attack the columnar epithelium because the columnar epithelium is single layer and it is very susceptible. The squamous epithelium, the stratified squamous epithelium in adults is very resistant to the diplococci, these Neisseria, but they are very commonly seen inside the bladder and even in the Bartholin gland. So Bartholin glands and the urethra are the most susceptible organs which get infected with Neisseria gonorrhoeae. Okay, so yellowish discharge, dysuria, very commonly seen, and the key word here is gram-negative diplococci, that is Neisseria. Then coming to the last question, this is again an overlap between biochemistry and OBGY. So I have basically added this question here because some of you had actually sent me these questions, but I think it was covered in the biochemistry section by Dr. Meenakshi Sundaram. So decreased sexual maturity and hypogonadism in men is seen with deficiency of what? Tell me, because there was a confusion between selenium and zinc. Definitely not iron, definitely not copper. Iron is for anemia, copper is, yes, so many minerals are required, but it is selenium and zinc. Yes, Anuj, the answer is zinc. Okay, you must have seen the recall, you must have gone through the recall videos. Now let me tell you the answer here. There is a tetrad of zinc deficiency, that is hypogonadism, acrodermatitis enteropathica, anosmia and dysgeusia. These are the words being taught to you in biochemistry lectures. Hypogonadism is seen in zinc, not with selenium. Spermatogenesis is functional, which is getting affected by selenium absence, by absence of copper, magnesium, so many other minerals. But the structural problem, the hypogonadism, is happening only with in the deficiency of zinc. Development of male reproductive tissues require an optimal level of selenium also, and a small deviation, either deficiency or excess, leads to abnormal development. Selenium and selenoproteins, they ensure the viability of spermatozoa. So it is the functional part which they are affecting, as well as providing protection against reactive oxygen species. So to protect the sperms from the reactive species and cause a proper spermatogenesis, selenium is required. Their absence during spermatogenesis results in abnormal spermatozoa, means teratozoospermia, which affects the semen quality, fertility. Deviation from the optimal quantities of dietary selenium may cause multiple abnormalities in the spermatozoa. Nowhere it is mentioned that it can lead to hypogonadism. So these are the details I got from a latest journal where the importance of selenium in male infertility is mentioned. Libido may also be increased by selenium. Dietary selenium should be in optimal quantity to maintain reproductive function in males and to avoid infertility. Okay, so when it comes to infertility, selenium is important, but hypogonadism means the proper formation of gonads is not there, then that is zinc deficiency. So thank you, children, that is all. Thank you very much for joining. All the best for your next exam. If you have any questions, you can always write it here. The live session will be over now, but you can always write it here, so my team can pick up and we can see if you have any questions. Do subscribe to the Manipal MedAce. If you do have you have time, then you can subscribe to the entire app, or you can just go for the crash course. We have done the prepathon also, I think just a month back, 1.5 months back, so you can go through those live sessions also. So all the best, and study well, sleep well, and don't worry. Okay, bye bye, take care.